العصب البصري أو الأوبتيك نيرف، وهذه الإشارات الضوئية بتصل إلى مكان في المخ، مكان في قشرة المخ اللي هي المنطقة المسؤولة عن حاسة الإبصار. طبعا قشرة المخ هنا بنشوف برضو شيء بيتحرك وبيقترب، تبتدي العين يصلها إشارات عن هذا الشيء. هذه الإشارات الضوئية بتصل لقشرة المخ، وفي قشرة المخ بيتم إدراك الشيء اللي العين بتشوفه. يعني بتتحول هذه الومضات أو الإشارات العصبية من إشارات عصبية إلى إحساسات يقظة. تجد الإنسان بيعرف الحاجة اللي الواحد بيشوفها إيه هي. كل ده بيتم في تناسق كامل طبعا، وفي أقل من يعني أجزاء من الثانية الواحد بيشوف الشيء وبيدركه. يعني هي حاسة الإبصار وحاسة الإدراك، دي الحقيقة منطقتين في المخ. يعني حاسة الإبصار اللي هي الفيجوال اريا دي موجودة في منطقة من المخ في الفص الخلفي اللي هو الأوكسيبيتال لوب، والفيجوال اسوشيشن اريا دي منطقة تانية برضو موجودة في الفص الخلفي للمخ، ودي مسؤولة عن إدراك الحاجة اللي الإنسان بيشوفها. visual association area. وكذلك بقية الحواس. هنا بنشوف كل خلية من المخ المخ بيحتوي على مجموعة من الخلايا، كل خلية ليها محور زي ما احنا شايفين. هذه المحاور بتكون الألياف العصبية، والعصب المخي ما هو إلا حزمة من هذه الألياف العصبية. وكل عضو من أعضاء الحس المختلفة الحواس بيرتبط بقشرة المخ عن طريق عصب مخي. العين بترتبط عن طريق العصب البصري بالقشرة البصرية اللي موجودة في الفص الخلفي زي ما قلنا. الإشارات العصبية اللي مسؤولة عن السمع، حاسة السمع برضو بتتنقل عن طريق العصب بتاع السمع لمنطقة موجودة في المخ في الفص الصدغي اللي هو temporal lobe. قشرة المخ بتشبه جهاز الاستقبال اللي احنا شايفينه ده، اللي هو بيستقبل الإشارات وبتحول في قشرة المخ إلى إحساسات يقظة يتعرف عليها أو بيدركها الإنسان. شبكات معقدة جدا من الخلايا والألياف العصبية بيصعب على الإنسان تخيلها. كل دي نيرف فايبرز اند نيرف سيلز بتعمل دوائر سيركتس داخل المخ تقوم بكل الوظائف المعقدة الحقيقة، وده بيعكس إعجاز الخالق عز وجل. عدد كبير جدا من الخلايا موجودة في كل وظيفة من الوظائف. على سبيل المثال حاسة الإبصار حوالي 100 مليون خلية، حاسة السمع 200 مليون خلية، حاسة الشم حوالي 300 أو 400 مليون خلية. هنا حوالي 4 مليون خلية بتتحكم في الجهاز الحركي، برضو الحركة ليها مكان في المخ، في قشرة المخ اللي هي مركز التحكم الأعلى في الجهاز الحركي. ده برضو بيطلع منه إشارات عصبية وبتصل إلى الجهاز الحركي، تجد الإيد اتحركت أو الرجل اتحركت الحقيقة. تذوق الأكل برضو له منطقة في المخ، إشارات بتطلع من منطقة اللسان وبتصل إلى منطقة في الفص الجداري للمخ اللي هو البرايتال لوب. الإنسان بيتعرف على الحاجة اللي بياكلها أو بيستطعمها. التوازن، جهاز التوازن مهم جدا ان يحصل توازن ما بين الايد وما بين الرجل. كل دي حركات بتستدعي هارموني، والهارموني او الانسيابية او التناسق ما بين هذه الحركات مسؤول عنها منطقة في المخ بتسمى بالسيربيلم او المخيخ. لو حصل اضطراب في هذه المنطقة بيحصل اضطراب في التوازن، حاجة بنسميها اتاكسيا، سيربيلر اتاكسيا. هنا حاسة الإبصار بتلعب دور كبير في احتفاظ الجسم بالتوازن بتاعه. الطفل له معدلات نمو طبيعية، وبالغريزة بيكتسب المؤثرات الخارجية. يعني المفروض ان هو الطفل يميز الضوء عند سن أسبوع، وعند سن شهر يبتدي يستجيب للأصوات، عند سن 3 شهور تبدو ابتسامة لطيفة على وجهه ويبتدي يتعرف على أمه، ويتحكم في عضلات الرقبة. عند سن 6 شهور يتحكم في الجذع ويبدأ في محاولة القعاد، يقعد. عند 9 شهور بيبدأ يحبي وقد يستطيع الوقوف، يقول كلمة أو كلمتين. عند سن سنة بيبدأ في المشي تقريبا، ويزيد عدد الكلمات اللي هو بينطقها. كل ده النمو بتاع الجهاز العصبي في الطفل. دي هي معدلات النمو الطبيعية. عند سن سنة ونص يبتدي يتحكم في التبول، ويبدأ في ان هو يعرف يطلع درجات السلم او ينزلها، والكلمات عددها تزيد. جهاز الأشعة المقطعية على المخ، وده أحدث طفرة في تطور تخصص جراحة المخ والأعصاب. طبعا يعني ساعدنا في التشخيص، بيبين لو في أي شيء عضوي في المخ. ده بيظهر على هيئة مقاطع بتبان في المونيتور على شاشة زي ما احنا شايفين، وبتتنقل وتتحمض. هنا المقطع بيبين أجزاء المخ المختلفة. المنظر الخارجي للمخ اللي هي الأخاديد والتلافيق اللي احنا اتكلمنا عنها، اللي هي سالكاي اند جايراي، والشعيرات أو الأوعية الدموية دي اللي بتغذي قشرة المخ. لو حصل انفجار في أحد هذه الأوعية الدموية بيحدث نزيف داخل أنسجة المخ اللي هو cerebral hemorrhage. دوائر معقدة جدا من الألياف العصبية بتربط أجزاء قشرة المخ بعضها ببعض، وبتقوم بكل الوظائف المعقدة جدا اللي بيقوم بها المخ. بلايين الخلايا العصبية. كل مركز في المخ مسؤول عن وظيفة، بيفقد هذه الوظيفة لو حصل شيء عضوي في هذا المركز. على سبيل المثال لو انقطعت عنه الدورة الدموية عن مركز الحركة بيصاب الإنسان بالشلل. جهاز التوازن بيلعب دور كبير في احتفاظ الجسم بالتوازن بتاعه. بتطلع إشارات عصبية بتتنقل عن طريق الأعصاب الحسية من مستقبلات الإحساس في الأطراف ومن العين، وبتصل إلى قشرة المخ. هذه الومضات الحسية أو اللي هي sensory impulses بينتج عنها بيطلع إشارات عصبية، ومضات حركية اللي هي الموتور impulses بتتجه من قشرة المخ إلى الجذع والأطراف، ودي بتبقى مسؤولة عن احتفاظ الجسم بالتوازن بتاعه. والجهاز الدهليزي اللي هو الفيستيبولار ابريتس برضو بيطلع منه إشارات عصبية بتوصل عن طريق الفرع الدهليزي اللي هو الفيستيبولار نيرف للمخ، وده بيبقى على اتصال بالمخيخ السيربيلم، وبرضه مسؤول عن احتفاظ الجسم بالتوازن بتاعه. كل دي وظائف أساسية جدا للمخ. كل منطقة مكلفة بوظيفة معينة. لو حصل خلل بجهاز التوازن بيحصل فيرتايجو اللي هو الدوار. الإنسان يحس إن الدنيا بتدور حواليه، ده بيبقى إحساس مرعب الحقيقة. الدوار ده برضو أحيانا في نوع منه بيحصل عند ركوب البواخر أو المراكب في البحر، بنسميه موشن سيكنس. مسؤول عنه الفيستيبولر ابريتس اللي هو الجهاز الدهليزي، وده بيتكون من القنوات سيمي سيركولر، قنوات الهلالية، سيمي سيركولر ابريتس أو كانالز. كلها خلايا عصبية مسؤولة عن التوازن. هنا الجهاز الحركي بيطلع إشارات عصبية من المنطقة الحركية في قشرة المخ متجهة للإيد، تجد الإيد بتتحرك. تسعين في المية من الناس بيستخدموا إيدهم اليمين، وفي قلة قليلة اللي هو 10% بيبقى الناحية الشمال هي الأقوى. منطقة في المخ مسؤولة عن الانسيابية بتاعة الحركة، دي اسمها الكوربس سترايتم أو الجسم المخطط. لو حصل أي شيء عضوي في هذه المنطقة أو حصل خلل في المواد الكيميائية اللي موجودة في هذه المنطقة، وخصوصا لو قلت مادة الدوبامين، بيحصل حاجة بنسميها الباركنسونيزم أو الشلل الرعاشي. الانسيابية بتاعت الحركة بتروح أو بتقل، تجد يحصل شيء بنسميه ريجيديتي. هنا بنشوف كل الانفعالات بتروح من الوجه، بنسميه ماسك فيس، يعني هذا الوجه متجمد لا تبدو عليه أي انفعالات، ما بيعرفش يعمل الزراير بتاعة القميص لأن الهارموني أو الانسيابية بتاعة الحركة بتقل، يحدث رعشة في الإيد بنسميها تريمورز. ده اللي هو الباركنسون ديزيز أو مرض باركنسون أو بنسميه شلل الرعاش. مسؤولة عنه منطقة في المخ بنسميها الكوربس سترايتم، الجسم المخطط. هنا العلاج بيبقى ان احنا بندي المادة اللي هي نقصت، اللي هي مادة الدوبامين، بترجع الخلايا تشتغل تاني، والإشارات العصبية بتتنقل بالطريقة المظبوطة وبتتحسن الأعراض. المواد الكيميائية دي بتبقى مسؤولة عن نقل الإشارات العصبية من خلية لخلية أخرى، ولو قلت بنسميها النيورو ترانسميترز، بيحصل خلل في وظيفة المخ. شبكات معقدة من دوائر عصبية بتعمل في تناسق تام عشان تؤدي وظيفة معينة، وكلها وظائف حيوية جدا وهامة للإنسان الحقيقة. التوازن، الهارموني، انسيابية الحركة، الحركات الإرادية، الحواس، مركز الحركة اللي بيتحكم في الجهاز الحركي، الذاكرة، مؤثرات خارجية أو معلومات بتختزن في خلايا المخ مسؤولة عن الذاكرة. هنا بنشوف إن المشي الخطوات بقت قصيرة جدا، حاجة بنسميها شورت ستيبج جيت، دي برضو حاجة بتميز مرض باركنسون، وبتبقى الذاكرة برضو ضعيفة في مرض باركنسون الحقيقة. لو هناك شيء عضوي، مثلا وجود ورم في منطقة في المخ، بتجرى جراحة لاستئصال الورم. لو حصل الورم في مركز الحركة بيصاب الإنسان بشلل. حصل في مركز الكلام بيصاب الإنسان بفقدان الكلام. حصل في مركز الذاكرة بيفقد الإنسان الذاكرة، بيحصل حاجة بنسميها أمنيزيا، فقدان الذاكرة. هنا بنعمل حاجة اسمها كورتيكال ماب، يعني بنرصد النشاط الكهربائي اللي موجود في الخلايا بتاعة المخ، نشوف لو كان في شحنة كهرباء زيادة قد تؤدي لحاجة بنسميها الإبيليبسي أو الصرع. مجموعة من المراكز الهامة: مركز السمع، مركز الإبصار، مركز مسؤول عن تذوق الأكل، حاسة الشم، مركز مسؤول عن التوازن، الحركة، الإحساس، الذاكرة، العقل. وهذه المراكز كلها بتعمل في تناسق تام. هنا الأحداث أو المعلومات بتثبت بداخل النواة بتاعة الخلية بتاعة المخ، وبتثبت على الأحماض النووية اللي هو RNA و DNA، وبيحتفظ بها الإنسان لفترة طويلة لو كانت في منطقة اللي مسؤولة عن الذاكرة البعيدة، أو لفترة قصيرة لو كانت المنطقة المسؤولة عن الذاكرة القريبة اللي هي الشورت تيرم ميموري، أو الذاكرة البعيدة اللي هي اللونج تيرم ميموري. ده بيعتمد على أهمية هذه المعلومات ومدى استيعاب هذه المعلومات. لو المعلومات دي مهمة أو الطالب قاعد يسترجعها ويذاكرها، بتتنقل من الذاكرة القريبة للذاكرة البعيدة. الذاكرة بتضعف طبعا في كبر السن، وده تطور طبيعي لتقدم السن، وقد يحدث شيء من الرعشة أو الهزة في الصوابع، ودي بنسميها الديمنشيا، أو اللي هي تدهور وظائف المخ المختلفة. ده قد يكون بسبب وجود نسبة من الضمور في المخ أو تصلب الشرايين اللي هو بيؤدي إلى قصور الدورة الدموية بتاعة المخ. طبعا جراحة المخ تطورت تطور رهيب جدا في السنوات الأخيرة. أحيانا بنحدث تحفيز، بنمرر تيار كهربائي بمقدار بسيط جدا علشان نتعرف على وظيفة أجزاء المخ المختلفة. لو عملنا تحفيز مثلا لمنطقة مسؤولة عن حركة الفم، تجد الإنسان بيحرك الفم بتاعه أو بيتحرك الشفايف بتاعته زي ما احنا شايفين. لو عملنا تحفيز لمنطقة الحركة اللي مسؤولة عن حركة الإيد، تجد الإيد بتتحرك. ده بنسميه كورتكس ماب، بنرسم الخلايا أو المراكز المختلفة وظيفيا على قشرة المخ، وبنتعرف على مكان كل مركز علشان نحافظ عليه أثناء الجراحة. تجد المخ بيتحكم في كافة أجزاء الجسم عن طريق استقبال الحواس. وفي قشرة المخ هذه الإشارات الكهربائية بتحول من إشارات كهربائية إلى إحساسات يقظة. تجد الإنسان بيتعرف على الحاجة اللي هو شايفها، أو على نوع الأكل اللي بياكله، أو على صوت شخص بيسمعه. دي اللي هي حاسة الإدراك، ودي من أقوى وظائف المخ. أو عن طريق خروج الإشارات العصبية من مركز الحركة للجهاز الحركي، فتجد الإنسان بيتحرك. وخدنا مقطع في المخ نجد إن هو المخ بيحتوي على جزء خارجي، وده بيسمى بالمادة الرمادية اللي هي الجراي ماتر، وجزء داخلي يسمى المادة البيضاء اللي هو الوايت ماتر. ونسيج العصبي بيحتوي على بلايين الخلايا العصبية. كل خلية أو مجموعة من الخلايا مكلفة بوظيفة معينة. كل الكائنات الحية لازم وجود مخ عندها، بس بيبقى مخ primitive brain بدائي. على سبيل المثال السمك 3 مناطق مهمة جدا: جذع المخ أو اللي هو البرين ستيم، والسيريبرم اللي هو قشرة المخ، والسيربيلم اللي هو المخيخ. المنطقة دي اللي هي جذع المخ والمخيخ والسيريبرم قشرة المخ. دي 3 مناطق المخ الأساسية. لو نقلنا لكائن آخر اللي هو الجوز أو البطة، برضو نجد ال3 مناطق موجودين. قشرة المخ، لو الكائن الحي ده مطلوب منه نسبة ذكاء أعلى بيبقى حجمها أكبر، زي القطة مثلا أو المونكي القرد. تجد إن هو الذكاء بتاعه بيبقى أعلى، فقشرة المخ بتبقى أكبر في الحجم من المخيخ ومن جذع المخ. والإنسان بيبقى طبعا أعلى نسبة ذكاء، وتجد السيريبرام بيبقى أعلى نسبة تطور عن بقية الكائنات، لأن مركز العقل مطلوب منه يقوم بوظائف أعلى بكثير من الكائنات التانية كلها. المخيخ بيبقى أسفل الجزء الخلفي من المخ، وجذع المخ هو عنق الزجاجة اللي بتفوت فيه كل الإشارات العصبية اللي جاية من مراكز المخ المختلفة، وبتتجه ناحية أو تجاه بقية أعضاء الجسم. ولذلك أي شيء بيحدث في جذع المخ ده مسؤول عن ضربات القلب والتحكم في التنفس وضغط الدم. هنا بتجد إن حصل موت دماغي اللي هو البرين ديث. القلب بينبض وتوقفت أجزاء المخ كلها ما عدا القلب اللي هو دي سيربريشن. دي منطقة جذع المخ اللي فيه كل المراكز الحيوية، التحكم في الضغط والنبض والتنفس. كل الإشارات العصبية من أجزاء المخ المختلفة بتعدي من منطقة اللي هي عنق الزجاجة زي ما احنا قلنا اللي هو البرين ستيم، جذع المخ. وده بيتكون من 3 مناطق: المظلة اللي هي النخاع، الميد برين اللي هو المخ الأوسط، والبونز اللي هو الجسر. والنخاع أو المظلة ده بيكمل على هيئة الحبل الشوكي أو السباينال كورد. في القناة بتاعة الفقرات. البلع السوالوينج بيتحكم في منطقة في المخ، والبلع من الميكانيزمز المعقدة جدا لغاية دلوقتي، أبعادها مش مفهومة، لكن هي كذا حاجة بتتم في وقت واحد. لو حصل خلل في الميكانيزم بتاع البلع تجد الإنسان بيشرق، بيحصل حاجة بنسميها شوكينج. المفروض إن القصبة الهوائية بتتقفل أثناء البلع، وده برضو كل التناسق ده مسؤول عنه منطقة في المخ. ده المخيخ موجود أسفل الجزء الخلفي من المخ، وده مسؤول عن التوازن. حصل أي شيء عضوي في هذه المنطقة بيحدث فقدان للتوازن، حاجة بنسميها أتاكسيا. وتجد حركة الإيد التوازن فيها بتضعف زي ما احنا شايفين، وبتصاب برعشة وعدم تحكم. السيربيلم المخيخ ده موجود أسفل مؤخرة المخ. لو حصل فيه مشكلة بيحصل عدم تحكم في التوازن. ده مسؤول عن الكوردينيشن اللي هو التناسق في الحركة، ولو حصل مشكلة بيحصل incoordination اللي هي الأتاكسيا، السيربيلر أتاكسيا، عدم توازن في الوقوف والمشي والحركة. منطقة الليمبيك سيستم ده جزء من الفص الصدغي اللي هو temporal لوب. مسؤول عن الذاكرة وعن الإيموشنز الانفعالات. الإحساس بالجوع له مكان في المخ، الإحساس بالشبع له مكان في المخ برضه. الإحساس بالعطش له مكان في المخ اللي هو الأبيتايت سنتر أو مركز الشهية. دي كلها قشرة المخ ومقسمة إلى مناطق. الجزء الخارجي اللي هو الجري ماتر، المادة الرمادية، والجزء الداخلي اللي هي الوايت ماتر أو المادة البيضاء. الوايت ماتر ده عبارة عن مجموعة من الألياف العصبية اللي هي نيرف فايبرز، دي بتربط أجزاء قشرة المخ بعضها ببعض اللي هو السيريبرال كورتكس. طبعا الجراحات بتاعة المخ حصل فيها تقدم كبير جدا. برضو هنا بنمرر أو بنقوم بعملية تحفيز للتعرف على أجزاء قشرة المخ المختلفة وكل وظيفة بيقوم بها هذا الجزء. الكلام مسؤول عنه منطقة في المخ اللي هي السبيتش اريا. الإحساس منطقة أخرى، الحركة منطقة أخرى اللي هي البري سنترال جايرس أو الموتور اريا، دي موجودة في قشرة المخ. لما بنتعرف على وظيفة هذا الجزء بنستطيع المحافظة عليه جراحيا واحنا بنشتغل أثناء الجراحة طالما عرفنا وظيفته ومكانه. لو انقطعت الدورة الدموية في شريان من شرايين المخ بيحصل حاجة بنسميها جلطة بتاعة المخ أو سيريبرال ستروك. وهنا الحقيقة الموتور اريا اللي هي المنطقة الحركية في المخ بتتحكم في الجزء المعاكس من الجسم أو النصف المعاكس من الجسم، وده ليها سبب علمي الحقيقة، لأن الألياف العصبية بتعبر للناحية التانية في منطقة بتسمى بجذع المخ أو البرين ستيم. فلو حصل إصابة للموتور اريا في الناحية اليمين من المخ بيحدث شلل نصفي الناحية الشمال زي ما احنا شايفين دلوقتي، يعني الوضع معكوس. هنا في منطقة في المخ اسمها الاسوشيشن ارياز، ودي لو حصل فيها إصابة تجد الإيد الشمال حركيا سليمة بس الإنسان مش مدركها، دي حاجة بنسميها نجلكت، يعني بينسى يستعمل إيده الشمال. هنا بالتنبيه يعني قلنا له إن أنت إيدك الشمال ما بتستعملهاش، ابتدى يحركها لأن هي الحركة فيها سليمة، بس حصل إصابة للأسوشيشن اريا فحصل حاجة بنسميها نيجلكت، يعني هو مهمل أو بينسى يستعمل إيده الشمال اللي هي الموتور أسوشيشن اريا. دي موجودة في الناحية الأخرى من المخ. لو حصل فقدان للنطق بيبقى يعني وجود شيء عضوي في مركز النطق أو مركز الكلام، وده بيبقى الحقيقة موجود في منطقة من المخ بتسمى ببروكاز اريا، منطقة بروكا. ده موجود في الفص الأمامي من المخ في الفلقات الأمامية السفلى اللي هو الانفيريور فرونتال جايرس. هنا زي ما احنا شايفين هناك منطقتين مسؤولين عن الكلام أو النطق. المنطقة الأولى اللي هي بروكاز اريا، والمنطقة التانية موجودة في التمبورال لوب أو الفص الصدغي. لو حصل إصابة في أحد هذه المنطقتين بيصاب الإنسان بحاجة اسمها أفيزيا أو فقدان للنطق، وده بيستدعي تمرينات على الكلام علشان يتحسن. إصابات الرأس برضو من الحاجات الخطيرة اللي بتؤثر على المخ، ودي أنواع كثيرة. قد يحدث كسور بالجمجمة، وقد يحدث مشاكل في المخ زي ما احنا شايفين. ده نوع من الإصابات بنسميه penetrating injury أو الإصابة النافذة، حاجة دخلت من المخ وعدت منه فعملت تهتك في أنسجة المخ وكسر بالجمجمة. طبعا هذه الحالات أحيانا بتتحسن زي الحالة دي، إن هو المنظر رغم إنه مرعب لكن العيان عايش الحقيقة. بيورينا الإصابة في الجمجمة اللي حصلت. لو حصل كسر منخسف أو نزيف داخل أنسجة المخ نتيجة الإصابة لابد من التدخل جراحيا لإزالة التجمع الدموي، وبنقوم بكي الشريان اللي مسؤول عن هذا التجمع الدموي أو لرفع الكسر المنخسف اللي هو depressed fracture، لأنه ده لو ضغط على مركز الحركة مثلا بيعمل شلل نصفي هيميبليجيا. مجموعة من الفلقات الجيراي، وده جهاز الأشعة الرنين المغناطيسي، ده بينقل الصورة أوضح من جهاز الأشعة المقطعية لأنه أحدث وبيعتمد على المجال المغناطيسي، فنسبة الريزوليوشن أو الوضوح بالنسبة للنسيج بتاع المخ بيبقى أكثر وضوحا من الأشعة المقطعية، بيبقى أكثر وضوحا من الأشعة المقطعية. لو في ورم في المخ مثلا أو جلطة في المخ أو تجمع دموي بنقدر نحدد مكانه عن طريق أخذ مقاطع. هذه المقاطع ممكن تبقى أفقية أو رأسية، ونقدر نستأصل هذا الشيء العضوي سواء كان ورم أو نقوم بتفريغ تجمع دموي الحقيقة.
Next, please. 100 cases of cementless total hip replacement were done in the Department for Trauma and Reconstructive Surgery, District Hospital, Lahr, Germany, from 1988 to 1990. Only 85 cases were available with radiological and clinical follow-up sheets at the time of preparation of the study and were included in the evaluation. Next, please. The preoperative diagnosis was coxarthrosis in 70.6%, avascular hip necrosis in 14.1%, revision for loose cemented prosthesis 9.4%, rheumatoid arthritis 2.4%, and fracture neck femur 2.4%. The mean age was 59.4 years, ranging from 33 to 75, and 45.9% were males and 54.1 were females. Next. The implant used in all the cases consists of the CLW ring, wheel ring, and CLS stem spotono, which are hip prosthesis components, both designed for cementless implantation. They are manufactured of a forged high-density titanium alloy and have a roughly sandblasted surface. The CLW ring, the wheel ring, has conical self-cutting threads which allow for immediate stable entry in the acetabulum. Next, please. The sandblasted surface supports bone ingrowth for further biologic integration. After implantation of the titanium ring, the polyethylene cup is inserted, which recently has been coated with multi-layer titanium mesh at its bottom to avoid polyethylene bone contact, which has proven to be a weak point in other acetabular component designs. Next, please. The conical shape of the stem in the frontal as well as in the sagittal plane affords a press-fit self-locking in the previously compressed spongiosus bone of the femoral shaft. Longitudinal pins anteriorly and posteriorly prevent rotation. The stem is combined with a ceramical head and a cobalt chromium molybdenum head is also possible. Next, please. Next, please. This is the instruments, the medullary remus. Next, please. Acetabular remus. Next, please. The patient spine, a lateral incision centered over the greater trochanter. Next, please. Iliotibial tract is open. The anterior third of the gluteus medius, periosteum of the greater trochanter, and vastus lateralis is incised and reflected anteriorly with a chisel. Next, please. The capsule is dissected free from the fibers of the gluteus minimus. Next, please. And Bowman retractors are put on the superior aspect, inferior aspect, and on the lip of the acetabulum. Next, please. The capsule is now fully exposed. Next, please. Next, please. Incision of the capsule in a T-shaped manner. Resection of the capsule. The neck is now fully exposed. The osteotomy in the neck. Next, please. Doctor. No, the one the osteotomy in the neck is made 20 degrees to the intertrochanteric line and 1 centimeter cranial to the lesser trochanter. 2 osteotomies are done, and the next, please, and the intermediate piece of bone is removed. Next, please. Next, please. The head is extracted. Next, please. Next, please. The acetabulum is now ready for reaming. Next, please. Gradual reaming of the acetabulum. Next, please. In the proper inclination. Next, please. Acetabulum is now reamed to the desired size. Next, please. The many radial cuts are made in the hard sclerotic bone in the floor of the acetabulum with a small chisel. Next, please. Trial ring. Next, please. The insertion of the ring. The ring is inserted inside the acetabulum. Next, please. The ring is fully seated in the acetabulum. Next, please. The debris, the acetabular reaming debris, are put in the floor of the acetabulum. Next, please. Next, please. The polyethylene cup is then inserted. Next, please. Preparation of the medullary canal of the femur. Next, please. Next, please. Next, please. Gradual reaming of the femur. Next, please. Next, please. Next, please. Insertion of the stem. This is the sputono stem. Next, please. And also reaming debris from the acetabular reaming debris are put around the stem. Next, please. The head is then inserted. Next, please. And reduction of the implant is done. Next, please. The mean operative duration period is 98.4 minutes, ranging from 70 to 250 minutes in a difficult revision case. The average period of hospitalization is 27.3 days. And the post-operative regime, as the support of the stem is mainly spongiosus, full weight bearing was delayed for 6 weeks to allow remodeling and bone on growth. Next. The femur, operative complication, the femur was fractured in 12.9% 11 cases, and those fractures ranged from a small fissure in the greater trochanter to a complete displaced fracture which needed refixation in 2 cases. The average follow-up period is 49 months. Next. All the cases were evaluated clinically for pain, range of movement, walking abilities, and activity level. Pain relief and improvement in movements are considered the most important factors in evaluating the clinical results. Radiological evaluation for neurotrophic ossification, signs of loosening of the stem as radiolucent lines, subsidence of the stem, calcar resorption, industrial bone formation around the tip of the stem, cortical hypertrophy, and change in the position of the stem. Also signs of cup loosening as change in inclination of the cup and cup migration were studied. Next. Next. 40 cases were considered good with no pain or slight on exertion and no limitation of movement. 38 were considered fair with moderate pain and slight limitation of movement, and 7 cases were considered poor with marked limitation and severe pain. Next, please. The mean improvement in flexion range is 42.8%. The mean improvement in abduction is 80%, and the mean improvement in internal rotation, external rotation range is 156.3%. Next, please. The incidence of heterotrophic ossification is quite high in this series, is 47.1, 40 cases, with only 1 case of complete ankylosis. 9 cases had radiological signs of loosening of stem. 2 cases required early revision because of the severe pain. The average subsidence of stem is 2.6 millimeter, ranging from 1 millimeter to 30 millimeter. Position of the stem was neutral in 62.4%, varus in 32.9%, and bulbous in only 4 cases in the post-operative X-rays. Next, please. The mean cup migration was 0.4 millimeter, with only 7 cases with cup migration more than 2 millimeters. The mean angle of cup inclination in post-operative X-rays was 51.7 degrees, ranging from 32 to 68 degrees. The mean change in inclination of the cup is 2.3 degrees, ranging from 1 to 13 degrees in only 4 cases. The change was 10 degrees or more.
Actually, prosthesis replacement and fracture fixation. Next, please. The known classifications for such fractures goes back to Johansson, 1982, proposed 3 types fractures. Type 1 fractures of the prosthesis around the proximal 2 cells of the stem, and type 2 fractures above the tip of the stem extending proximal and distal, and type 3 fractures which are entirely distal to the prosthesis. Siruki in 1992 had extended this classification to include the 4th type of fracture with comminuted pattern extending below and distal to the prosthesis. Next, please. As far as the material we are talking about today, it's comprised of 13 cases that have been treated in Sterling Garden in Hungary. This was also in central Scotland. And this figure represents about 1.2% of the total number of hip replacements which have been done in the similar field. The average age of the patients was 73. As far as the etiology, minor trauma was responsible in 10 cases. 2 cases have bone surgery and 2 others have bone defects. Next, please. The duration between having hip replacement and fracture was on the average 8 years, and the types of the arthroplasty were 3 yearly arthroplasty, 8 primary total hip, and 2 revision arthroplasty. Next. The management, 2 cases had been treated conservatively. 1 was external fixation, 5 had open reduction and internal fixation, and 5 had revision and fracture fixation. As we can see, all patterns of fractures have been represented in the series. Next, please. The results. The fixation group, we had, I would say, conservative group. The results for the 2 cases that have been treated conservatively. The first one ended in non-union after 8 months, and the second one united after 18 weeks with loosening of the femoral component. As far as the fixation group, we had 1 patient who had external fixation and 5 who had open reduction internal fixation, 2 with DCP and 2 with DCS, and 1 with cartilage plate. We'll go through the fixation group now. Next, please. This 82 years old patient who had ring arthroplasty in the late 70s and 25 applied for 15 years apart from having this massive pelvic bone dislocation. And he had a triple trauma that ended in time for fracture. Next. This one was treated with osseous fixation for 9 weeks. Next. And ended in varus deformity and shortening of 1 inch. Next, please. This lady, 86 years old, had osteomorphosis for 6 years, and her x-rays showed progressive femoral component loosening. Next one. And eventually she made it after a triple trauma and sustained type 1 fracture. Originally the plan was to treat her conservatively after first x-ray after 3 days in bed. Next, please, showed displacement of the fracture. So a plan to do cartilage plating for her was done. Next, please. Her first post-op x-ray showing perfect reduction, and within 6 weeks the prosthesis starts sinking and rotating. Next one. 5 months post-operatively, the prosthesis settled in stable position and the fracture healed, and 2 years later the whole case ended in external rotation of 40 degrees and another inch shorter. Next, please. This 82 years old, sustaining type 2 fracture after another minor trauma. He had DCP plating. The prosthesis intraoperatively was found to be stable, so internal fixation was just done. Next one. 6 weeks post-operatively. Next one. 3 and 6 months post-operatively showing perfect union and prosthesis is stable. Next one, please. These patients who had total hip replacement for 7 years start showing evidence of stem failure that ended in complete break in the femoral stem. Next. Doing revision arthroplasty mistaken for data with distal femur, which ended in 3 months in complete break. This fracture was added to fixation by DCS. Next, please. As far as the results of the open fracture internal fixation, as we saw, all cases had type 2 or 3 fractures. Fractures were spiral or oblique, and radiological union was achieved within an average of 5 months. Touchdown weight bearing was allowed in the first week, and some form of partial weight bearing was maintained throughout the whole course. Steady union was achieved. We had one case of loosening with external rotation, deformity and shortening, the case which had been treated with partial straight. Next, please. Now, the revision and fixation group, we had 5 cases. One of them had been treated with a long-stem prosthesis together with fixation of the fracture with a clamp plate and circumferential wire, and 4 cases that had revision with a clamp plate. Next one. This is the first one, having type 2 fracture after having total hip replacement 8 years earlier. Next, please. Intraoperatively, the prosthesis was completely loose and had to be removed, and the fracture was fixed with circumferential wire and menin plate. Next one, please. Now, the other 4 cases had a Kent hip, which had proved to be very helpful in the management of such cases. The Kent hip combined the feature of femoral prosthesis together with the benefits of intramedullary, long intramedullary knee, which allows us to fix the fractures by the virtue of interlocking transverse screws. And it's completely versatile. It comes in different stem lengths and diameters, and 2 neck offsets, as well as a full set of head, modular head components which would match all the current sizes of hip arthroplasty components. Next, please. This is the first case, an ordinary fraction in the femur that had a Bateman bipolar hip arthroplasty. 2 years later, next one, please. The patient had a minor trauma that ended in this type 4 fraction. Next. We had to remove the whole component and fix the Kent prosthesis, the femoral component only. We didn't have to do anything for the acetabulum because we could manage to put the metal frame of the bipolar prosthesis on the head of the Kent component, so we carried on as a bipolar prosthesis. Next one, please. 6 months post-operatively achieving good union and full function. Next one, please. Another situation where the Kent prosthesis proved to be of great help in the management of this difficult revision arthroplasty, which I was very likely to end up with. Next one, please. Almost straight or shattered upper end of the femur, and in such cases it's hardly to fit any sort of the conventional hip arthroplasty components. Next one. We managed to pass a long stem in prosthesis with interlocking screws, and the patient had an excellent function within 3 weeks post-option. Next one, please. This is the X-rays follow-up after 6 months and 2 years. Next one, please. This is the last follow-up X-ray. Next one, please. Now, after seeing some of the options for the treatment, whenever we are planning any sort of treatment in such cases, we should think of 4 parameters: the patient, factors, the fracture pattern, the prosthesis, and the hospital resources. For the revision and fixation group, all patients had either comminuted type 2 or 4 fractures, and the femoral component evidence was loose. The patients were allowed partial weight bearing from the first post-operative day, and full weight bearing was resumed within 6 weeks. We had only one complication with case number 13 that had external rotation deformity 30 days. Next one. As far as the conservative treatment is concerned, we should understand if we are going conservatively, it means a very high risk to the patient and enormous burden on the nursing staff. And even if you are lucky to end up in union of the fracture, is very high incidence, up to 50% incidence of loosening of the femoral component and ending up in a deformed upper end of the femur, which would make revision arthroplasty as a secondary procedure extremely difficult. Still, in my opinion, there is a place for the conservative treatment in 1 or 2 situations. Either, number 1, physically fit patient that can stand the whole course of treatment, type 1 fracture with stable prosthesis and adequate nursing staffing and physiotherapy. Next one, please. As far as open reduction and internal fixation, the advantages we had was the accurate reduction, the immediate stabilization, and the procedure was much less difficult than reversion arthroplasty, but the proper union might take between 4 to 7 months, and it's difficult to assess in the X-ray, and as any internal fixation, it carries a risk of non-union in 10%, gate failure, stress riser effect at the junction between the prosthesis and the plate. Ideally, we should think of open reduction with internal fixation if the patient is of limited functional demands, having type 2 or 3 fractures with good bone quality, and the prosthesis is stable. Next one, please. For reversion arthroplasty, definitely provide a comprehensive solution for the whole problem, but the procedure surgically is a massive procedure, and technically it's very demanding, and it carries all the hazards of reversion arthroplasty. And the ideal situation for this type of treatment would be the fit patient with a high functional demands, intact segment tested with a fraction, the prosthesis is loose, with adequate hospital resources. Next, please. Thank you very much.
And secondly, by a patient self-assessment system with the patients receiving a postal questionnaire. The results of these two surveys have then been sent back to London to a medical statistician, and he has done a comparative analysis on the results. The last 200 cases have been reviewed by my colleague, Dr. Neves. We have a 14 years follow-up with an average of 7.2 years. The work was done in my hospital on the south coast of England, Southwest Hospital, which is 450 beds, and we have 96 orthopedic beds, of which 12 are a dedicated joint replacement unit, where we mostly carry out total hips and total knees. We have a theatre only used for orthopedics, which is a laminar flow theatre providing filtered air. The infection rate for this series was 1.7%, in most of the cases being in the early part of the series. Now, the knee prosthesis is now rather old-fashioned, but it's a long series. The denim knee prosthesis, as you see there, is a stemmed prosthesis. It relies on intramedullary alignment so that accurate alignment is achieved, and the femoral component is set at 7 degrees of valgus. The tibial component you see there is aligned on the intramedullary rod so that that can reliably be put in horizontal to align with the tibia. Up to 1987, that was the standard denim prosthesis that was used, and then working with denim, I modified the tibial component by tilting the tibial plateau back 10 degrees to produce an anatomical shape, and that increased our average range of movement up to 105 degrees. So the average range up to 87 was only 78 degrees, and afterwards 105. Obviously, the ability to flex the knee is important in elderly people getting up from a chair. The operation is done through a midline incision. The patella is dislocated laterally. You can see the femur prepared there, ready to accept the femoral component, and the tibia is being cemented in place on the intramedullary guide rod. On the right-hand screen, the excess cement is being removed, having put the femur in place. The straight line incision sewn up at the end. We always drain the wound. All patients are given anticoagulation treatment. They mobilize on day 1, and most patients are getting home between 1 and 2 weeks from surgery. At operation, the passive range of movement of the knee is recorded by extending the knee and then testing passive flexion and recording it. So this is the type of patient that we're dealing with, average 73 years old, mostly female, about 2/3 to 1/3 female. The age range included a 22-year-old juvenile rheumatoid arthritis, Still's disease. Apart from him, it was a range from 45 to 91. Osteoarthritis was the majority of the cases, but rheumatoid was a high proportion with 40%, because that's a particular interest of mine. That's the typical appearance of an OA knee and the amount of bone removed. No cases were excluded from this series. We dealt with, particularly in the early part of the series, very severe deformities of the knee, unstable knees, and as you see on the right, a case of rheumatoid arthritis where multiple joints are stiffened up and we have fixed flexion deformity of knee and hip. The range of motion on the operating table was recorded and then compared with the range of motion at an average of 7.2 years follow-up, and you see it's decreased, so that we're now about 105 degrees range of motion compared with our over-optimistic 120 at surgery. Patients rising from a chair, and this is the direct comparison between surgeon's clinical assessment of outcome with the patient's own assessment. 51% told the surgeon that they could get out of the chair easily, and only 29% when they filled up the same type of questionnaire themselves in the privacy of their own homes. This is a trend which goes right through the series, and this work is being done on 9 orthopaedic surgeons' work, apart from my study, and the trend is throughout all 9 surgeons. Climbing stairs, 18% recorded by the surgeon, with only 5 climbing normally when the patient reports it. When you come to a fixed criteria, such as the inability to climb stairs, then there's much closer agreement. You'll see that we've returned 11 and 10% in both surveys. Walking distance, again assessed by the surgeon, comes out optimistic, with 83% saying they can walk more than a quarter of a mile, and only 61% of patients admit to that. When you measure a fixed criteria, such as the inability to go out of the doors, then there's close agreement. The use of sticks, again, shows an over-optimistic surgeon's report. In both cases of not having to use sticks and having to use 2 sticks or a frame, the surgeon comes out more optimistic. And we looked at complications, and this is a rare complication. Over 90% of patients did not have any instability, but this is the case where there was gross instability and the lady required further surgery, in fact to have a ligament reconstruction. Pain assessment was rather difficult to evaluate. Again, we see the optimism on the part of the surgeon when asking about whether there was any pain at all, 61% to 52% of the patient. But if you take the 2 categories, none and mild, together, then both patient and surgeon are fairly much in agreement. Works out at about 82 to 85% have no or mild pain, and that's remarkably close to the success rate of the operation. On the right is the only case of heterotopic calcification after knee replacement that I've seen, and that wasn't associated with pain and stiffness initially, but did resolve, although the range of movement never improved much. The success rate, as judged by patient and surgeon, was remarkably close. 86% telling the surgeon that they thought their knee was better, and 86% returning a report that the knee was better. The conclusion of our survey is that a surgeon assessment of clinical outcome will give an over-optimistic result. And another important factor is the expectations of the patient. This young man is going to expect and demand a lot more of his knee replacement than the little old lady who is going to be happy if she could just walk painlessly to the shops. My lady is happy because she can climb the stairs without pain, and she's not expecting to be able to walk up the top of the pyramids. Thank you very much.
Osteoarthritis of the knee. Next. Unicompartmental osteoarthritis of the knee is a common condition among Egyptian population. High tibial osteotomy by various techniques is a standard procedure for treatment of this condition. Treatment is based on the principle of restoring alignment of mechanical axis of the limb to relieve excessive asymmetrical loading on the knee. Next. Previous techniques are very demanding and complications have been frequently encountered. This includes 1. Vascular and neurological injuries, early fractures or late flattening of tibial plateau. Implants are required for fixation, are liable to joint penetration, infection, loosening, and removal. Next. Difficulties in reaching and cutting the posterior cortex has necessitated partial or complete excision of the fibular head. Next. The aim of this work is to present a proposal of a new technique for high tibial osteotomy and to demonstrate a sample of early results. Next. The principles of the new technique involves a V-shaped osteotomy carried out from the lateral aspect of the tibia. And the V-shaped, the posterior part of the V-shaped, the proximal part of it has been carried out using a gigli saw first, and then the limb has been marked by drill holes carried out from the lateral aspect to the medial aspect of the tibia, and then completed by an osteotome, which is very thin. Next. And here is a cadaveric specimen has been done to demonstrate its function and use. These are the drill holes has been carried out from the just proximal to the tibial tubercle and extended about 5 to 6 centimeters at the middle part of the tibia, and then the cut that is done posteriorly has been carried out using the gigli saw. Next. The cut is completed using an osteotome. Next. And then if we measure now the angle of correction, we can see that first this is the neutral angle and the pins are parallel to the joint line. Next. And here is correction by valgus, varus. This is valgus correction, and on the right side is the varus correction. Next. So we can have about 60 degrees range of correction, whether valgus or varus correction. Our material consisted of 12 patients, 10 were males and 2 females, and the average age was 54.4 years, and the mean follow-up period was 3 months. Next. The technique of the operation involves first cutting or excision of part of the fibula. Next. Next. And then an incision is being carried out to the lateral aspect of the proximal tibia, extending about 10 centimeters to the distal, to the tibial tubercle, and to the fibular head. And then with a specially designed retractor has been done and developed by the author, has helped very much protection of the posterior vessels and the lateral popliteal nerve. Next. And here is the osteotomy. It's been marked and then cutted using an osteotome. And on the left side and on the right side is the K-wires has been marked in order to denote the angle of correction. Next. And here, after completion of the osteotomy, now we can correct about 25 or more degrees of varus or valgus correction. And on the right side, disclosure of the wound has been carried out. The operative time usually is 20 minutes. Next. The post-operative regime The patient's leg has been put in an above-knee cast for 1.5 months, during which non-weight bearing is begun for 3 weeks, and then partial weight bearing for another 3 weeks. Exercises began for 2 weeks, and then full weight bearing as patient tolerated the pain after 8 weeks. Next. Early results next. Here is a patient with a gunshot injury and complete collapse of the medial condyle of the tibia, and it has resulted in marked varus deformity. And here is a post-operative correction by the new V-shaped high tibial osteotomy. Next. Here is another patient with a severe marked osteoarthritis with varus deformity, and here is a medial post-operative correction of the Next. The right side is corrected by the old technique of the excision wedge osteoblastic, while the right side and the left side is the new V-shaped osteotomy. And we can see here that there is no extension of the lateral condyle over the excised distal fragment of the tibia, while the new V-shaped distal osteotomy, proximal tibial osteotomy, we can see at all the osteotomy. Next. With another patient and post-operative correction. Next. Here is an example patient. You can see that the varus correction, and on the other side, the left side has been corrected, and nearly the mechanical axis of the limb has been nearly and almost corrected. Next. And here is the patient's movement at 2 months post-operative. Next. Here is the lateral view to show that there is no extension or flexion deformity of the patient, and this is his X-ray. Next. Discussion. The expensive costs of the unicompartmental arthroplasty has limited its popularity in our country. Proximal tibial osteotomies for degenerative unicompartmental osteoarthritis provide pain relief for most patients for a reasonable period of time. Next. The most frequent complications of the closed wedge osteotomy is improper correction of the deformity, as it is controlled by the amount of resected wedge. But the new V-shaped high tibial osteotomy offers great advantage in this respect, since change in correction can be done, if required, during the first postoperative week by selectively wedging the cast. Next. Peroneal nerve injury has been reported following the closed wedge high tibial osteotomy. The use of a specially designed retractor for protection of both the popliteal vessels and the peroneal nerve, and the non-touch technique of the fibular head and its ligaments have prevented this complication. Next. Perforation of the popliteal artery has occurred after the barrel vault osteotomy. Next. The use of the giggly saw to cut the posterior cortex of the tibia, protected by the author's retractor, has made it completely safe against vascular injury. Also, the fact that the osteotomy is carried out from the lateral to the medial is another point for more safety. If severe deformity of the proximal tibia is present, excision of a large wedge may result in shortening of the tibia, flattening of the lateral condyle due to incoaptation between the wide proximal and narrow distal cut of the osteotomy. Next. And here's to show this incoaptation of the excision wedge osteotomy. Here is the limb of the excision wedge. If we move the distal part of the osteotomy upwards, we can see that more load has been loaded to the lateral condyle of the tibia, while it is unsupported down by the distal part of the tibia. While in the V-shaped osteotomy, the wide surface of the osteotomy and the complete coaptation between the surfaces has helped very much relief of pain immediately post-operative. Next. Conclusion. The new V-shaped osteotomy is simple, quick, and reliable. Previous complications have been avoided. Next. The operation is recommended for treatment of unicompartmental osteoarthritis of the knee and for mild to severe degrees of varus or valgus deformities. Thank you very much.
Not big athlete. You may want to follow conservative route of therapy, rehab, bracing, and see whether or not he can function. If he can, then you have an option. And most of us know that if we have a torn anterior cruciate ligament, we may have intermeniscal tear or medial lateral or meniscocapsular ligament separation of the posterior horn of the medial meniscus. This is not an uncommon entity. Whether or not that is going to cause or create functional disability on a patient is very hard to determine. The problem of associated chondral injuries is very difficult to detect on physical exam. So the X-ray is going to show anything. And if you have, suspect that the injury was quite massive, then you may think about doing arthroscopic surgery, not right away situation, but within limited time, based on your environment and preparation. Because if you got a bad chondral injury, you may need to do something. So my indication varies from person to person, patient to patient. If you got MCL and ACL injuries where the possibility of dissection of the fluid from the knee to the calf is quite high. So in those cases, if you do this, be careful, because you may hurt the patient more by doing acute arthroscopic surgery. So I don't have any hard and fast rule saying that this acute injury, I'm going to do arthroscopic surgery. I'm going to select the patient depending on the patient, my time, my convenience, and look at it. If you know that this is a young athlete and you're going to need a reconstruction of the ligament, then let it quieten down, get some motion in the knee, and then try to do reconstruction of the ligament at appropriate time. At that time, if you're repairing a meniscus, you can do these. So those things vary from person to person. So I can't give you a clear-cut answer that any acute hemarthrosis, I will do arthroscopic surgery. Answer is no, but still vary person to person.
Dr. Nassar?
In Switzerland, I think we do it more or less the same way. I think there are situations which force us to be very acute. That means, for instance, knee dislocations. But there, I doubt if a arthroscopy is necessary. In most cases, the ligament ruptures are so manifold. You have 2 cruciates, you have 1 collateral, and the whole capsule on one side. And normally, it is as dangerous to do arthroscopy, but I think in these cases, the instability is so marked that you have to do acute ligament restoration. In most cases of acute knees are in our area are meniscus tears, and they do not need to be operated the same day, even when they are locked. I think you may wait over the next day, they are no more locked. And it depends now upon the patient. When he is an orthopedic surgeon, for instance, I think he would like to be active very quick again. So he would not like to stay at home or to walk and have recurrent lockings. So I think he will decide to have a very quick surgery. The same in a sportsman, in a young sportsman. Sport is his profession. He earns his money with sport, so he tries to be back on the field as soon as possible. So in these cases, we do regularly. The next day, we do arthroscopy, or we do what has to be done. Normally, we do not do anterior cruciate reconstruction in the first week. We also prefer to gain some motion within the knees before we start to do reconstruction of the anterior cruciate.
Hi,
right, I will agree with Dr. Patel and Dr. Nosberg about arthroscopy. One should be rather conservative in arthroscopy in acute knee injuries. As most of these cases, you can reach diagnosis before arthroscopy by examination and examination under anesthesia. So the role of arthroscopy will be limited to about 10% of cases. In these cases, one should judge that arthroscopy in acute knees is a bit difficult, and what you are going or the information which arthroscopy will give you, most of these you have obtained by examination. However, in some cases, arthroscopy may prove helpful, as in those cases you can differentiate between those anterior cruciate which will need repair or reconstruction. So an avulsed fragment, you may proceed to repair of the anterior cruciate, or in cases of locked knee. But on the whole, there is no rush, and it needs judgment, because sometimes it proves harmful. If you have a collateral ligament injury, arthroscopy may be harmful, may be disastrous sometimes, as it may affect the vascular status of the patient. Thank you.
Thank you very much. I gathered from previous discussions that one should be very conservative, as you said, in acute arthroscopy in the knee. One should be very selective, and one should think, what is the patient going to lose if this is not done acutely? Not only what are you going to how are you going to help him, what damage will happen if the knee is not accurately looked in. There is no actually much to be lost. I gather from what Dr. Patel has said that his indication might be if he suspects a big chondral fracture. Is that right? Then your indication, or main indication, if you suspect a big chondral fracture, you just find
if there is severe trauma,
yeah,
and where the MCL is intact, or if there is a actual trauma and some twisting,
yeah,
then you may suspect that there is a possibility there may be chondral fracture. You may want to get an MRI. There's also a chondral fracture, the condyle tibia.
yes.
Then you may want to look into early. Similarly, I forgot to mention one more condition, that if you have a avulsion of the tibial tubercle,
Yes.
with anterior cruciate,
It's
it's not emergency right away situation, it's your elective time, because it requires not a middle of the night situation. You need to get videos and all kind of things. So those things are beneficial for the patient.
And I understand from you, Dr. Nosberg, that your indication is in the one who is eager to know what's wrong with his knee and wants to go back as soon as possible. Then this might be an indication to look inside and tell him what's wrong and try to manage whatever is there. Orthopedic surgeons and elite athletes.
There is always a question whether we should arthroscope when we have a hemarthrosis and we have no clinical diagnosis. And should we do arthroscopy in every case? Maybe not very acute, but maybe next week. Or are there cases where we can just wait and see, as a matter of fact, as we did some 20 years ago?
I think a wait and see policy is a good policy, especially when you are not respecting something major inside you that needs urgent interference. What I would suggest in most of the cases that one would aspirate the tense hematologist, apply a cryocuff, cool the knee, and put him in a sort of a splint that rests the knee, and advise quite safe exercise. And once he is settled down, you'll be able to have a better clinical impression of what's going inside the knee, and then you put your indication for surgery at ease.
I think in the Journal of Bone and Joint Surgery, there was published maybe a year ago by some of the, maybe by you too, I do not remember, but by several famous American arthroscopists, that they have the impression that too many arthroscopies are done. And I personally have the impression that in Switzerland also the young residents, they tend quickly to say, let's do arthroscopy before they have exact clinical diagnosis. And I think we should go on to teach our young residents first to make clinical evaluation, and then to have an idea before you do arthroscopy. It's like reading a book. I think you have to have an idea what you are going to read, otherwise you do not profit enough.
Any questions? Go ahead, please.
Can I ask? Yes, please.
I don't know, but I maybe disagree with the panel. I feel that we have to differentiate between an urgent arthroscopy, an emergency arthroscopy, and a next day arthroscopy. I would agree that there is nothing that emergency arthroscopy, because there is no vital organs are going to be hurt if we delay the arthroscopy for the next 24 hours or 48 hours. But if we say that we delay the arthroscopy 1 week or 5 days, it will mean that I will have a very thick synovia due to the reaction of the hemarthrosis in the knee joint, and this might prevent the real visualization of the knee. I have actually 2 examples in view. In particular, when you have the spaghetti type ACL rupture, what is the sense of waiting? Is it then to wait until you have a synovitis reaction, or then it is a real stability? That means if I cannot diagnose it on the first spot that this is an unstable knee and it will be reconstructed, what is the sense of waiting then?
What are you going to gain if you do it after 1 week, for example? You are not going to reconstruct the anterior cruciate anywhere early, because it's well known now for fact that the incidence of fibrosis after acute reconstructions is unacceptably high. It's always preferable to operate on a quiescent knee with a nearly full range, and you insist on achieving full extension, in particular before starting operating on the knee. I mean, acutely torn anterior cruciate ligament is not an indication for acute interference or acute arthroscopy or acute reconstruction. I mean, if the knee is tense and painful, you go ahead and aspirate the knee to ease the patient, put a cryograph and spin the knee. This will prevent further progression of hemarthrosis and will help in reducing the inflammatory reaction, and everything will settle down. And then you can think at least whether he needs arthroscopy or not.
Well, it has been said and written up by a number of people that if you do reconstruction of the cruciate ligament early, the possibility of fibrosis is quite high. Don't know the reasons, but that's what they say. So quite a large number of people now wait, aspirate the knee, get some motion, some electrical stim, bicycle, whatever they want to do, and get fairly decent motion, and then do these. The other thing is the fact that most of the people, when you have an acute rupture of the anterior cruciate ligament, almost all of them will do reconstruction. And really, they don't do repair unless the tubercle is pulled off. So you can do reconstruction today, or you do reconstruction 4 or 5 weeks later. So most of the people feel that doing early reconstruction, the possibility of fibrosis is high. So I think that is the main reason. The trend is toward doing it later.
I think the problem is also that sometimes there may, in winter time in our area, there may come 5 cruciates a day. And beside the total hips and knee, total knee prosthesis and other fractures, this is just too much. So we have to plan. We cannot do these, I do not like to make anterior cruciate at 2 o'clock in the morning. Then I'm tired normally if I work out there. So if you if you say you should do it immediately, I agree. If you stay at home in the hospital, wait and have nothing to do, then finally one cruciate comes, okay, go on.
Differentiating between an urgent arthroscopy, an emergency,
And next morning.
the next morning. That's the green line.
The point is that you should look at it in that sense. What is a patient going to lose if you don't do the arthroscopy, say next morning or within the first week? What harm is going to happen to the patient if you don't do it? And what benefit is he going to get when you do it?
You will have an inflamed synovium.
The aspiration and cryotherapy and rest would be good enough to settle this down.
For how long?
Yeah.
3 days?
3 days, yeah, okay. And then start mobilizing.
Yeah, 2-4 weeks.
Do you operate immediately on
It's at 1 o'clock at night, I will not operate.
Yeah.
If it comes at 5 o'clock in the afternoon, I probably will still do.
The problem is there's a lot of difference between the private practice and national health service practice. And I found myself, for example, I never did an operation the next day or two for NHS, which I'm not ashamed, I'm not proud of it. But I always do it privately. When a patient come to me with an injury with ACL or without or meniscal injury or locked knee, I usually do it within a week, within 2-3 days. But if I come to NHS, I do it within 2 to 4 weeks, depending on how I fit him into my business. And the danger is, if I leave him for 2-4 weeks in private practice, sometimes they go somewhere else. So naturally, I'm sure that is the case in Egypt here as well, which is very important consideration. Even in England, I mean, we have. Now the other thing about ACL has better results in coronary. Obviously, everybody writing about that, but the case in England, we operate, although I didn't do it myself, on our top athletes the same day or next day, and our top football player, Gaza, which has his IQ matching his age, is actually has his operation, which is the best football player in England, the same day, and so other top players because it's been done within 6 to 12 hours of sustaining the injury. And they did extremely well. Now, I'm not suggesting that everybody should have such a service, but I'm just saying that when it's done properly, but an experienced surgeon will do it, I think the difference might be 6 times the private practice than me that he operated. And when I noticed just last 6 months that I'm exactly like him. So we all are guilty of the same practice.
So in one case for NHS, the patient suffers. In private practice, you suffer.
Yeah, I'm just.
I just want to add something. If there is urgency in treatment, if you have something that is going to ruin the knee, so you have urgency, you're going to do it urgently to treatment. But for diagnosis, I think that 90% of these cases you can diagnose clinically. That's what I want to.
Actually, I have a comment about the acute reconstructions that were made after a few hours from the injury. This must be very individualized and should be limited to patients like the quality of patients you have mentioned. That you know their demands, and you know that they are highly motivated so that they will not get stiff, and you know for sure that the degree of injury they have will not allow them to go back to the same level of performance that they had beforehand. So you put your indication depending on the demand, on the patient's demand. And of course, it should not be generalized at all. It's not unacceptable as a general rule.
Is a basic tools for every orthopedic surgeon. We must learn it and we must know it. This is no more somebody tell me, I rather open the joint than do arthroscopy. This is first. And we are in the Middle East here, not in that standard yet. There are a lot of hospitals in my country where they don't do this routine arthroscopy. This is the clinical data, the clinical information on acute injury of the knee is rather questionable because the knee is, the patient is in pain. You cannot test him very well. and there are a lot of X-rays taken in not good positions, where you don't know whether there is a subchondral fracture or any bone injury, and then the consequence will be that ligamentous injury also due to the hemarthrosis and to the synovial inflammation or the tension in the knee joint is definitely will not give the surgeon the assurances of the diagnosis. Therefore, I consider that arthroscopy is a tool, is a very good tool to give the surgeon the indication, whether to give him the diagnosis, whether to do or not to do. This is then something that we debate on.
I beg to differ again. Okay, when you do it urgently, within the first or second day, and what harm will happen if the diagnosis is delayed for 1 or 2 weeks? Sometimes you may not have to do anything.
Run away. This ACL, okay, can wait or whatever. But if there is tense hemarthrosis, if there is severe pain, and you have the possibility to lavage and aspirate the knee, is there any harm to doing it the same day? You said there is no benefit, but if there is any harm?
Immediately after the operation, they have learned to contract their muscles, and they have learned already for rehabilitation. So I think if I am almost sure that an anterior cruciate will be the problem, I will not do arthroscopy. And I think you should not do twice arthroscopy. I think it's not worth it. It's too costly if you do arthroscopy just to wash out the knee, and then if you had to do a meniscus suture, then you decide, oh, this is too difficult for me, I need somebody else to do meniscus suture. So to do just as a diagnostic tool, arthroscopy, day one, and then to decide to do another arthroscopy to do the therapy, I think that's wrong. It's too expensive.
You have a clinical diagnosis more than likely what's wrong with the patient. If he has a torn cruciate ligament in a young athlete, you know you're going to do reconstruction. So you use arthroscopy not as a diagnostic tool, but as a tool to facilitate your reconstruction. And at the same time, if you see a meniscocapsular ligament is disrupted, you believe in repairing it, you do this. Or if a large osteochondral defect and you think you want to pin it to remove it, you can do this. But I use arthroscopy primarily as a surgical tool to fix things. And if you have to do this, might as well do in an environment where you are not sleeping, the nurses are not sleeping, you have a comfortable time, and do in an environment which is suitable for better results. And we know that acute reconstruction of the ligament, ligament reconstruction done acutely, has a higher possibility of fibrosis. So why bother with it? You can reduce the pain by washing out the blood from just irrigation from the large needle, take out the blood, ice packs, motion, pain pill, maybe crutches or whatnot. You'll be amazed how good they feel once you remove the blood. So I just have to, I'm a selfish person. I like to do it at my convenient time.
In acute arthroscopy, if we want to do cases with severe locked knee, if we want to do them in the absolute athletes like the gentleman from the United Kingdom has spoken, this may be considered. But generally, the patient should err in his operation. So we should treat him conservatively first, aspirate his knee motions, and after cold compresses and so on. If he does not settle subsequently, we may go in and do whatever we need to do. After having the appropriate diagnosis and after having the planned surgical procedure under cold conditions, rather than coming and changing the whole pattern to make a new pattern that everyone having a new trauma of the knee should be in the middle of the night being arthroscoped, and arthroscopy will be an emergency procedure. I think this is too much for such a procedure.
hiding it and removing the blood, ease rehabilitation and make it faster. This is one point. The more important point, do you not feel that meniscal repair results are far superior the earlier they are done, and that leaving a meniscus which is partly torn might transfer a partial tear into a complete tear and then compromise the final outcome? So what does the panel feel about meniscal repair in acute situations? I'm not talking about the same night situation, but rather the next morning.
The other point is that delaying of the meniscal suture for 1 or 2 or 3 or even 4 weeks or 2 months does not actually compromise the result of suture of the meniscus. We are talking about weeks and not years. So there will not be enough damage to the meniscus itself, or it will not affect that as much as you think the outcome of the repair. Aspiration of the knee, simple aspiration with a white bore needle will rid the knee of the blood inside, and it will actually make the rehabilitation quite fast. And the patient has avoided urgent surgery, unnecessary anesthetic, and the possibility of going in and out without doing much.
Make a comment on, see, if you think that you want to do meniscus repair, you can, but unless you do reconstruction, it won't work. The likelihood of that meniscus repair failing is quite high without reconstruction. So we have a patient, we think there is a high possibility there is meniscovascular separation, meniscocapsular separation, then you want to do this. So if you need to prepare him, then it's going to take you at least a year for you to be good enough to resume athletic activities. So repairing doing arthroscopic surgery primarily to repair the meniscus without reconstruction may not work. So and also you know that you can do meniscus repair at 2-3 months later if you wanted to do this. Together with reconstruction, that may work. So I would separate between the two things. Just doing early to repair, doing that alone may or may not work, but I think you need to do reconstruction at the same time. Yeah.
Except reconstruction. Because when we was just resident and we taking our diplomas and so on and so on, in Watson Jones' textbook, if you get a very good quadriceps, training the patient conservative, and he got a very good quadriceps that he can lock the knee, he will have a very good functional knee. And I was amazed. Since few months, patient came to my clinic complaining of pain in the knee. He has osteoarthritis. I told him that he will need a total knee. He just came to me, no, I don't want, just relieve the pain. And he got my papers when I was just resident. He had a frank posterior dislocation of the knee. How many ligaments are torn in this situation? Imagine, all the thing, I reduced the knee, put him in POP, exercising, and he is a worker, heavy worker. He's a farmer, digging, driving, making all the things in his farm, and he's just complaining of pain, of osteoarthritis. And that's why I'm asking, how many patients with ACL tear will accept to have a reconstruction of this, unless he is asleep and wants to go to athletic parts, just like this. And I have, last week, I have one, all the signs of ACL tear are present. I told him, okay, you are going to do it. That's fine. What?
Well, as you rightly said,
what?
A torn ACL by itself is not an indication for surgery. We are treating the disability, not the instability. Patients with symptomatic ACL tears request treatment, we not even suggest treatment. They request something to be done for them to stabilize the knee. معلش كان في كده واحد في الأول
reviewed. Somebody reminds me about the Swedish champ. There's one who works on sports injury quite a lot. I remember his name now, but anyway, Ericsson, and he has reviewed those, and 10 years and 15 years even people with ACL deficient knees, and there is no osteoarthritis. So I don't think one should go every ACL limb repair. Going back to this emergent arthroscopy, I don't think we should arthroscope the knee in every injury, but I think one should not delay the arthroscopy. If it's indicated, and if the patient has got any problems, then we should not delay it, because if you pick a small vertical tear in the posterior hole, for example, early, it's nice, but if you leave it and the patient just has another injury and another injury, then that becomes probably a bucket-handed tear or complete peripheral detachment, or he may lock his knee and damage his knee, and so on. So I think we should not delay the indications. And the indications mean that one has to be in a high skill as far as the clinical assessment of the knee is concerned. History and clinical examination, and probably MRI, but not necessarily. But one has to be right on the tips of his toes as far as the clinical aspect of the whole problem is concerned. Then you pick the early damage, and then you can.
Much more than he does need to be examined arthroscopically. And it's quite easy to give him anesthesia to be sure of the magnitude of the ligamentous injury he had. And I think to limit arthroscopy for 3 situations. If you aspirate the hemarthrosis and you got tear, then there may be a rupture there or an osteochondral fracture which is not seen in the X-ray, or in a locked knee where you can get an acute meniscal lesion that you can deal with it at the same time, or if you empty the knee and you get the grating sensation on flexion essentials, then there may be a cartilage lesion there which is not seen in X-ray. The question raised whether the unstable knee can get osteoarthritis or not. Of course, an unstable knee can get osteoarthritis. And this question is complex, and it depends on many factors, but how much you need from your knee, how much you exert your knee, and how much frequent the knee gives way. If the knee has no anterior cruciate function and is not, the patient or the individual is not asking too much of his knee, then this knee will go on safely without any trouble. The question raised by Professor Said, how many of patients with ACL can agree about having reconstruction? We had a prospective study on this subject, and we found that 30% of patients with symptomatizing ACL deficient knee can do well with physiotherapy. And in this respect, it is important to strengthen the hamstring, much more important than to strengthen the quadriceps. But patients can agree definitely to have ACL reconstruction if their knee is always healing in their daily use at least, or if the patient has or asks for a very stable knee for a facilitated activity or something. Thank you.
To know, apart from the easier ones, which is to diagnose an acute anterior cruciate ligament tear, is probably the easiest thing to diagnose in an acute knee. How many acute hemarthrosis can you actually adequately diagnose clinically? Could the panel answer in an acute situation in 24 hours? And then if you're going to delay the arthroscopy for 2 weeks, what added benefit will you get by delaying it for 2 weeks instead of relieving this patient's pain after 24 or 48 hours?
2 weeks off as a sick leave, and then you will arthroscopy. That means then you will do the reconstruction. For me, as in a private sector, calculation-wise, I'm not talking about my pocket. I'm talking about the patient. Calculation-wise, from his job, he will lose much more or the, let's say, the calculation of the society and the compensation. This will cost more than not doing the surgery. I just want to conclude this point.
It's not only this it can detect. You certainly cannot do a pivot shift test in the acute situation. So I presume that maybe 7 out of 10 patients, unless you MRI them or anything, you will not be able to give them a diagnosis. So if you are going to do the arthroscopy within a week, do it within 24 or 48 hours.
Right, no problem.
No,
Second thing.
Excuse me. I'm saying that the easiest thing to diagnose is an anterior cruciate ligament tear. That in the other conditions, of course, if it's a complete tear, if it's a partial tear, you cannot detect it. But I'm saying that osteocondylar fractures, peripheral meniscal tears, meniscal tears in general, all these conditions you're unable really to diagnose, and you really need to make a diagnosis.
But what is common is common. When you have an hemoarthrosis, mostly it is due to anterior cruciate in 70% of cases. If you arthroscope this patient, right, if you found something to deal with, it's okay. But if you found the mid-substance there in the anterior cruciate, so what you are going to do? Are you going to reconstruct the patient immediately, or are you waiting?
No, I will watch the knee and get the benefit of this patient going home painless or with very little pain, and rehabilitating very fast, regaining his range of motion, so that you can do the reconstruction at an earlier stage and get him back on the route.
I think we agreed on aspirating the knee, so the patient will go home painless.
Last night. I don't think you have the same.
But you can, yeah. It's hard to be consequent, you know. It's. I published once, maybe 15 years ago, you should do arthroscopy as an emergency in every hemarthrosis. I just don't do it anymore. And I did not do it in my boy when he fell on his knee and he had the hemarthrosis. And I said, let's wait. And,
I might make a comment about arthritis with torn anterior cruciate ligament. I think all of us know that if we lose the instant center of motion, then stresses across the joint will be quite high, and you may get potentially more stresses, maybe more cartilage damage, maybe arthritis. What we're presuming now that by doing reconstruction, we're going to restore the instant center of motion. I think it is not like fixing 2 bones of the forearm. You know, if you got broken 2 bones of the forearm, we know it isn't going to heal, and the patient is also not going to function, more than likely. So you plate it, and it's more than likely it's going to heal. With a torn anterior cruciate ligament, all of us have seen patients who function very well, who have functioned well without cruciate ligament. We also have seen patients who have had reconstruction of ligament and have got arthritic changes in the knee, and have 10-15% of patients have problems. So it is really, there's too much emphasis put in that if you don't do reconstruction, you're going to have arthritis. Some people will say if you don't do reconstruction, you're going to have disability or instability. But there are football players, there are hockey players, and there are a lot of sports athletes who do very well without reconstruction. So it is a very debatable question. What I would say is that you really have to individualize the patient. The patient is not running away from you. If he's not functioning well, if he's having disability, you can look after him very well. The other point I might point out that if you have a torn medial meniscus, like a bucket handle tear, and you have to do reconstruction of ligament in the future, it's quite possible that you may not get as much arthritis as you think you get. So repairing the meniscus, small repairing the meniscus, doesn't, with the reconstruction of ligament, may be the same as removal of the bucket handle tear and reconstruction in times to come. I'm not sure. I'm just saying to you, these are food for thoughts you need to think about. Because there are patients who have bucket handle tear, remove the bucket, are able to go back to function quite well, and have come back a number of years later, and you don't see any X-ray changes. So there's so many things happening in the science. We really don't have any control. They have, some patients have bow legs, so they have more pressure on the medial side. Some people have valgus knees. Some people are loose jointed, tight jointed. So this control environment is very difficult to protect. So all I would say is that let's play by ears. Just go one at a time. If it's myocyte, sit tight a bit longer. So that's what we talk about. That's what I would do.
Back to your question. I haven't.
The message now, I'd like to clarify the situation for myself and the other audience. As we are frequently using the arthroscope, most of us use as diagnostic aid to diagnose cruciate ligament, not necessarily